And then you find a very subtle polyp sitting inside it, and you say, okay, now I'm justified in treating this girl. And you know that the hysteroscopy is going to give her the answer. So the first thing she's going to ask you, tried everything, nothing has worked. Here, she will have the answer. You will also realize when you do a lot of this, that there is not just one disease a lot of the times. What you find is that there is more than one disease process going on. So sometimes it's simple, echogenic polyp, endometrial polyp, we are happy. Hypoechoic lesion here, adenomyomatous polyp, you're happy. This polyp shows one branch divided immediately into multiple vessels. Benign vasculature always gives off one side vessel and goes on to become a narrow vessel. Anything that is dichotomous branching or trichotomous branching is likely malignant disease, and you have to handle it accordingly. Therefore, you will never depend on an image like this, you will go on to make an image like this one. Here is a single horn uterus, uterus as we call it now, or unicorn like we used to call it earlier, and it has a large polyp in it. So both need to be addressed in this patient who has infertility. In this girl, we have two polyps, and if you remove just the big one and look at the small one, someone's going to discover that because she's going to have the same symptoms. So we can't do that. So you need this kind of a map to handle this. And here again, you find that yes, not such a nice looking thing, too many vessels going inside. We tried our best to delineate, we couldn't delineate, but the vessels made us suspicious. And so she had a hysteroscopy, she had a good hysteroscopic sampling of various parts of the endometrium, a complete curettage, and this was a cancer of the endometrium. And the clue was just bizarre little vessels. We have simple techniques also when you don't get delineation, such as what we call VCIA. VCI, you add up sections, and because you add them up, you get better contrastiness without using radiological contrast. Many lesions perhaps. Perhaps, maybe not. What is happening here? I don't know. I switch on my VCIA. 1 polyp, 2 polyp, 3 polyp, 4 polyp, but the outline is nice and neat and clean. And therefore all she needs is a nice hysteroscopic cleaning up of this whole thing and end of her symptoms. And we're very happy. So that is how simple life becomes. Then of course it becomes very simple in things like adenomyosis fibroids, which we will discuss shortly. But one thing I want to show you before we conclude this particular section is how we look at Mullerian abnormalities. And because we now show things so clearly, we don't have to depend on pictures like this that don't give us detail from the older kind of technology. We go on to use the newer kind of technology, which is demonstrate the layers, to demonstrate the fact that you can tell whether a uterus is septate or not, because we have new definitions, and clearly tell the difference between this. Because we go by the new classification, and it's still very useful, although a lot of people criticize it, but this is the ESG classification 2015, which said there is a normal uterus, there is a dysmorphic, which is a T-shaped uterus, there is the septum, and you can have a shallow septum or a longer septum, but more importantly, when you have a dip in the fundus, and you have this big area here, this is a bicorporeal septate uterus, which will benefit from surgical resection in patients who have recurrent implantation failure and recurrent spontaneous miscarriages. Extremely important. And then, of course, the others, which is a hemi-uterus with a without a canalized horn or an absent uterus. And therefore, you go on to demonstrate this. And in that situation, you will demonstrate very clearly how thick is the septum. Because the septum is no longer described as arcuate or septate. It's either normal or it's septate. When you measure the myometrial thickness, it is this orange line, and it's the line from the fundus down to a horizontal line that connects the ostium. And the yellow line is the actual septum. If the septum is more than half of this line, then it becomes a septum. Otherwise, it is arcuate and will not benefit from a surgical procedure. And then you have lesions like this, where you have suspected that something is terribly wrong on the 2D. You reconstruct, and it's a septate uterus, shaggy outline, and then this mass here. And this was endometritis plus fibroids in the septum. So therefore, you have to handle the endometritis and you have to handle the fibroids as well. When it comes to this septum, a lot of patients say, do I need surgery or do I not need surgery? And in that situation, there's a prognosis factors where you don't have to wait till she has a third miscarriage. And that is that in that same wide uterus I showed you, some of them would happily carry on and have a baby. But if the length of the residual cavity is shorter than the length of the septum, she should be fast-tracked to surgery. If the septum is vascular on day 10, and I say day 10 because the septum is always vascular during the period, and it is always vascular during the mid-cycle. But if you find on day 10 of a cycle, when the septum is supposed to be avascular, if you find this there, this is truly acting as a pacemaker, and everything is coming out as a miscarriage. Therefore, you have to be very careful and make sure that this septum is fast-tracked to surgery. And of course, you can calculate the endometrial volume. So these are some very simple things that you learn about the Mullerian abnormalities. And you also understand something very important about the T-shaped uterus. We used to think it was congenital. Now we know in our part of the world that this is chronic inflammatory and often tubercular. But there are two types. They are the ones that have a fairly decent myometrium, and the one that are tubercular, where the myometrium is already eaten up. If you were to attempt a lateral metroplasty to make this T-shaped into a triangle on this kind of a uterus, I'm sure you would end up with bowel and momentum in your resectoscope. You can't afford that. That's a disaster. And therefore,